Good morning and welcome to the Substance Abuse Awareness Lecture Series number 2. And this one is on opiate addiction. And so we'll talk about withdrawal or detoxification, and then we'll talk about opiate maintenance treatment. And I am Gale Springer, the mental health clinical nurse specialist, and we have several people in the room today, so I will be calling on them, asking them about their experiences, not with use, their experiences with treating patients who have been using. Let's see, I'm going to start with a quick little reflection this morning. And I want to do the 5-chapter story. Maybe you guys have heard this before. It's a common theme in addiction treatment. And the 5 chapters goes like this. Chapter 1 is you're walking down the street and you fall in the hole. So you get into addiction. So chapter 2 is you're walking down the street. Now you know the hole is there, but you still fall into it. And then chapter 3 is you're walking down the street. You know the hole is there, and you don't want to fall into it, so you try to skirt around the hole or something like that, but you still fall back into it. And then chapter 4 is you're walking down the street, and you know the hole is there, and you try to barely skirt around, and maybe you kind of get around the hole. And then chapter 5 is you walk down a different street. So I just think that patients who come here with opiate addiction, it's a great time for nursing staff to work with them on, often it's a crossroads, and it's a catalyst for them to make some significant changes in their life, and we want to capitalize on it. So we have a great opportunity. Many of the patients we see are the ones who are septic because of their opiate addiction, some kind of infection in their system, in their blood. We see a lot of osteomyelitis, abscesses, endocarditis related to opiate addiction. So it's an opportune time to really work with these people and give them maybe a different path. So that's the thought to start out with. So I have fewer slides today than what I did last week. Okay, so we have some learning objectives, and first is really how to have the discussion regarding opiate detoxification versus opiate maintenance treatment. So I just want to go through that with you because you are the group that sees the patients first. And then the next thing I want to just talk about is opiate detoxification process. And I think I'll be a little bit more brief about that because my hope is that we really are detoxifying them, that we are really identifying medications to use for opiate maintenance treatment. And so here are some of the pearls that I just wanted to kind of think about and just put it as the top of our discussion is the treatments for opiate dependence is really very important given the very devastating consequences. And we are seeing the devastating consequences of, the opiate problems for families, and that there's, a lot of child protective services. They're losing their kids. They're living on the streets. There's tent cities. There's drug use at all of the parks now. People who take their kids out, you go into the bathroom and you see the needles in there. You see people who've overdosed. Just even if you are in a path in life and you're not in that, you can't get away from it because it's pretty much everywhere. So devastating consequences. Medications are really targeted towards detox or maintenance. We use agonist maintenance therapy. It's really the current recommended treatment for opioid dependence due to its very high superior outcomes. And I think maybe we have in the past not really focused on getting our patients on some kind of agonist therapy. We turn them around pretty quick and send them home. And we've really not treated the issue that brought them here, the underlying issue. is the goal, to get there, and then they won't keep coming back. So, let's see, detox programs really have limited long-term efficacy. Is really because there's so many issues regarding how uncomfortable people with opiate addiction feel. And they have like almost an 80% rate of return back to drug use in the detox programs. So we got to ask, is that really the path? We want to probably be working on some kind of agonist maintenance therapy. Something else to think about is that when our patients come in and they have addictions history with opiates, we want to make sure that we realize they're going to need more meds. And so how many of your patients, when they come in with an opiate addiction, are you able to actually get a history from?
Very rare.
Very rare. So what you're doing is detective work. You're sort of taking a diagnosis and thinking, it's likely related to an opiate addiction if they're, you probably do good observation skills and you look for the track marks. And the track marks can be anywhere. Obviously, forearms are the first to go, but you can find them legs, and then when they lose their veins, they start to muscle it. There's also a small group or group that come in that are just smoking it and really never have gone to the actual using the needles. But I mean, there's still evidence there. We try to look through the record to find out if they have an addiction history. So the medications, the opioid agonists, the partial agonists, the alpha-2 adrenergic agonists, and then the opioid antagonists. So that's pretty much what we're focusing on today. So the methadone is likely the one that you are often, I wanted to have the discussion. How do you have the discussion with the patient regarding when they first come in? Do we put them on methadone or do we keep them on just short-acting opiates? And my hope for this talk today is that people will at least pause and think before they put them on methadone. Because methadone is a great drug and I love it, but if the patient doesn't want it and they eventually want to be on Suboxone, it's a lot more tricky for me to get them there on that path. I prefer that we just stick with maybe short-acting opiates. So, or we use long-acting opiates and then short-acting ones for the breakthrough pain. So a combination versus actually putting them on the methadone. But methadone, for some patients, it's great. It really works. We start with a dose. So somebody asked me last week, where do we start? So we usually start between 20 and 30 milligrams a day. Dr. Karen, our addiction specialist, likes to go up by 10 milligrams a day. So every day, 10 milligrams. I think there's going to be some opiate withdrawal order sets coming out that actually talk about the induction process for methadone. And I think they're using they're starting out with like 10 milligrams 3 times a day, and then each day they go up by 5 milligrams per dose. Anyway, it's methadone has great research. It's been studied a ton, and it has great efficacy, and it works well. For some people, it's hard, the daily attendance, to get there, but you can only get the methadone for opiate addiction from a methadone maintenance clinic. Let's see, I guess the one that which makes us to stop using the methadone is that prolonged QT interval. And I think that is happening maybe higher in our percentage because we see sicker patients here in the hospital, but the research says about 16%. but I have started to see it a lot for those people who have been on methadone for a long time. Another thing to think about methadone, it only gives us 6 to 8 hours of pain management. So rather than doing once a day dosing here in the hospital, let's divide it and give it 3 times a day. That's the other, if we can do that, sometimes we just get much better stabilization for our patients. And let's see. Okay, so if the patient comes in with a really long history of using a lot of heroin or another opiate, then we often think methadone might be the better choice over the buprenorphine because it really works for people who have a higher percentage or higher dosing. And then the other tip is make sure we call the methadone clinic to find out the dose. I can't tell you how many patients I've had that have stretched their dose. So that's important to do. And okay, and then the partial agonist is buprenorphine. So have you guys started giving buprenorphine here? Are you giving Suboxone much?
Not in an inpatient setting.
Okay, that's going to change. I think we are getting flooded now with Suboxone. The barrier we have at our hospital is we don't have very many waivered providers. So to be able to prescribe Suboxone on discharge, you have to be a waivered provider. In beginning of last year, they opened it up for ARNPs to become waivered. So great news on that. And many of the ARNPs are getting on board with that. Not so much in our hospital, but out in the community. So we do have a process here in the hospital to get people on it. The great things about it is it has a higher affinity to the mu opioid receptors than methadone. Than almost any other drug except for the antagonists like the Narcan and the naltrexone. So the thing about it is if you give it, it has a ceiling, since it's a partial agonist, it has a ceiling effect. So you don't get the overdoses that you can get with the methadone. And we also know that but because of that, it also has maybe not quite the same level of management of the pain issues, the chronic pain issues. So it's more of a low-level kind of pain management medication versus methadone, which is a higher level. So it is a combination drug. So the Suboxone is what we're giving. And it's a combination drug, so it's a 4-to-1 ratio. And and if you give it sublingual, it doesn't. The naloxone does not absorb. It's only when they crush it and try to inject it, then the naloxone works. So they did the research to find out the proper ratio, and that's the one that they found out works the best. So really, it's a diversion prevention that the naloxone is in there. Pretty cool, huh? Pharmacy at its best. Let's see, teaching elements. When you give it, remember that it's sublingual. I hate to tell you this, how many nurses have given it orally because they put it in their cup of pills and give it to the patient, and the patient swallows it. And so, just a reminder, pearl for the day is make sure it goes sublingual under the tongue. And our addiction specialist really focuses on it should be, 20 minutes before and 20 minutes after no food or fluids, because he says that affects the absorption. So if we aren't getting the best results from it, it's likely the patients have not been doing it sublingual. I cannot tell you how many patients I've rounded on that we started and they're taking it orally. So Again, it only gives about 6 to 8 hours of pain relief. The good thing about buprenorphine is often given morning and evening, or we can again give it TID for even better. Okay, so I'll talk about that in a minute. The other one is the alpha-2 adrenergic agonist, and that's clonidine. And you guys probably do use clonidine, right? I mean, it really works. The research is coming out good. And it's a non-narcotic, so it's helpful to have. No abuse or dependence. It does really help with the tearing, the runny noses, the muscle pains, the restlessness. The problem is it causes pretty significant hypotension, which might be a problem for you guys. And we can give it 3 to 4 times a day. And then our opiate antagonist is naltrexone, and we have the ability to give the Vivitrol shots here. We got some kind of grant, and so our pharmacy can give it. The problem is I have to get the patients like 7 to 12 days without any opiates before I can start it. And some patients, that's what they want, but it really is a high affinity to the new opioid receptors, so it really blocks any properties of an opiate. And so if you need to have pain control at some point, it's a tough med to have if patients have been on it. The other thing is we try to monitor the liver function tests, and the research shows that you can still give it if they're like 3 to 5 times higher than normal. You can still give it. Okay, you guys use ketamine here, right?
Increasingly more so.
Yeah, okay. And it's really a dissociative anesthetic. But there is some research around it in using it for opioid addiction. And it does reduce the cravings, prolongs abstinence, enhances the neuroplasticities, it reduces depression. And so they did a research study on the dosing, and if you are at higher doses, you get a better outcome than lower doses. Like the psychedelic doses. What doses do you guys use here?
I'd have to look at it.
Okay. Okay, and then the COWS is really our basic assessment skill that we look at. I recommend we do it every 4 hours in PRN. These are the symptoms that it measures, and I think that even when we start with an opiate replacement therapy, that we should continue the COWS because we really need to monitor for withdrawal symptoms and make sure we're on the right dose. The other thing is that it can sometimes pick up diversion. Now, patients do sometimes things that they think they're doing in their best interest. And for some patients, they have found that if they take half their dose and sell the other half, then they have some money to live on. They're just trying to survive. So these are the adjuvant medications, lots of them. I think the research shows we want to give some kind of sleep aid. Typically we think trazodone or Seroquel. Our addiction specialists like Seroquel. Other addiction specialists like trazodone. The thing about Seroquel is it is an antipsychotic, and there's some monitoring of using antipsychotics for non-antipsychotic needs. So just the system sort of monitors that. But certainly I like the hydroxyzine, the Bentyl, the Neurontin, the Imodium. We use sometimes the B6 for the nausea. And then our detox protocol at our drug and alcohol unit, they use scheduled Tylenol, ibuprofen, and Flexeril round the clock for 3 days, the first 3 days of withdrawal. And they still use withdrawal medications, and they are still using benzodiazepines, but that, I don't know, might change. because there's a lot of research around using buprenorphine. Everybody needs a follow-up treatment plan because once we start them on methadone or buprenorphine, then we have to make sure we connect them with an ongoing facility because we are not able to give a prescription. We can only give like a 30-day prescription for the buprenorphine, so we're not monitoring. We have to make sure they're connected with the provider. Fortunately, in our community, there are tons of new buprenorphine providers. So there's Ideal Options, Catholic Community Services, CMAR, and then all of the community health center docs have now become buprenorphine waivered. So that's great news. And then if they have insurance or Medicare, Providence Drug and Alcohol Unit has a buprenorphine clinic as well. And then just know that the patient's cravings are like all-consuming. The one way I like to think about it is if you were in Germany in the time of the Nazis and they came to your house to take your kids away, you would do everything in your power. You would lie, you would steal it to protect your kids. And that is sort of the power of the cravings of the addiction. Kind of just puts it in a perspective for all of us, of that they will do anything they have to do to protect their addiction. That is the nature of it. That's how powerful those cravings are. And they have really a lot of ambivalence about, their treatment, and I think we can work with ambivalence, and that's fine. They're also very afraid of healthcare workers because they're afraid that you will take away their drug, you will put them in withdrawal, and withdrawal has been very miserable for them. And when the patients are able to tell their story, we want to make sure we really thank them, assume that they're doing the best that they can, set up some kind of relapse prevention plan which talks about triggers, warning signs, and recognizing that it's very hard to ask for help and it really takes courage. And then this is our new Suboxone protocol in the hospital. And I just wanted to share with you that again, we talked about the opportune time, and starting doing the Suboxone induction is much better in a hospital setting because we can use medications to make it a successful intervention. About 50% of patients are lost in the outpatient setting because the first 24 hours they are not able to tolerate it without the opiate. And so the expectation is they go about 12 to 24 hours to be opiate free. You have to put them in withdrawal before you start the buprenorphine or the Suboxone, which is a combination of buprenorphine and naloxone. And so usually we think with OxyContin and MS-Contin, it's about 24 to 36 hours before they go into withdrawal. Methadone, it's like 36 to 96, so we're looking about 4 days. And then oxycodone, it's about 12 to 24 hours. So the way that we do it with methadone is we stop the methadone and put them on short-acting oxycodone. And then we wait our 5 days, and then we go into our opiate-free period. And during the opiate-free period, we use all those adjuvant medications. We've started to add a little lorazepam to sort of ease their opiate-free period. And we are doing pretty successful getting them through. And it's just amazing the difference you see in the patient once they get stabilized on Suboxone. It is absolutely fabulous. So we start with the test dose of 2 milligrams. If they do okay, then we add 6 more milligrams. And then our typical dose is 8 milligrams, sublingual, twice a day. So, ending thought. If you had diabetes, no one would ask you when you're getting off your insulin. So that same thought is for the opiate replacement therapy, and they're on methadone or Suboxone. They need it now to survive. There's been enough brain chemistry changes that they need that. But you look like you have questions. Any questions?
Maybe later.
Can you think of anything? What do you think about this stuff? We'll be doing a lot more in this hospital.
Interesting to see how they transition with the current plans.
Yeah. You mean the physicians or the patients?
All of the above.
Yeah. Yeah. It's, some doctors are far more comfortable with the methadone than the Suboxone. But I think that will change in the next 5 years. There's just too much good research to show how beneficial it is. Anything else? Thank you for coming.